Welcome. I'd like to go over and do a little introduction to theories and models of treatment. Varied philosophies underlie your approach to your client. And that was the point behind my initial request for you to post about what you know about substance abuse treatment. You can go back and then look at what you know and what you said you knew about substance abuse treatment and think about it in context of underlying assumptions and approach to models of treatment. From my point of view, there's three main models of treatment. The disease model of addiction, psychological model, and sociological model. In the disease model, we deal with medical terminology and physiological factors. And these include things, we run into terms like prevalence and incidence and risk factors, comorbidities, and inherited factors. In the psychological model of addiction, we think of issues as learning and habit and other primary disorders. Under the sociological model of addiction, we run into the influence of location, where somebody lives, their race, their ethnicity. We encounter the real power that poverty has in terms of influencing our lives. Simply speaking, each of these views lead to different interventions. Let's look at each of these in a little more detail. In the disease model, we have a certain utility. It defines the framework of our approach. Ask yourself if substance abuse disorders have the common components as medical conditions do. In any disease, we usually expect to find symptoms, signs, progression, and course. And with substance abuse, these vary based upon the substance used. Substance abuse has the potential to have multiple impacts on other conditions. Key among these is alcoholism, where it impacts hepatitis C and diabetes quite frequently. A disease usually has established mortality and morbidity statistics, and oftentimes there's a heredity factor that determines the risk for disease and may include predisposing factors. I know I present these different models in stark contrast as if they're mutually exclusive, even though we realize that they overlap quite a bit. But in the pure psychological model then, we'd find that it presumes that addiction is a secondary condition. It's basically due to something else. We use a psychological explanation for the symptoms of the addiction, whether that be other conflicts, lack of individuation on the part of the patient, or the famous oral fixation that comes out of Freudian thought. The psychological model then also references both classical and operant paradigms, and it's as complicated as learning theory in general, because what it does basically is it links habit from classical conditioning along with volition or operant learning, and it has a rational theoretical kind of position, if you will. You drink because, and there's an explanation. I think this appeals particularly to psychologists due to the basic human need to have a compelling explanation for existence or for a particular characteristic or trait. If we continue looking at the psychological model, we find that it allows for controlled drinking, because if drinking is learned, it can be unlearned. This was very popular and prevalent in the 70s. The psychological model, saying that it really comes from something else, is supported by the argument referencing comorbidities. We find a lot of mentally ill chemical abusers and chemically addicted mentally ill. The MICA is the addict who develops a secondary mental disorder, such as the alcoholic who becomes depressed. Or the CAMI, who, an example would be the schizophrenic, who finally uses enough substances, oftentimes multiple substances, to produce signs of addiction. So with either of these, we run into the issue that addiction oftentimes is viewed as an acting out of other conflicts. And basically, if you encounter in your professional career the MICA or the CAMI, you'll be forced to try to answer for yourself the proverbial question, which came first? The sociological model identifies social measures which define substance abuse and dependence, where in the psychological model or the medical model there's an illness or disease or disability. The sociological model views addiction as deviance. It considers addiction to be secondary to social and largely economic forces. Treatment focuses on supportive interventions around other life tasks. Success is really congruence with the norm, the social norm. This is quite different than the medical model, which envisions cure of a disease or bringing the disorder into a state of remission. It's also very different than the psychological model, where the focus is on the individual pathology or habits, and the goal is a change in behavior. It's interesting to look at these three models as they manifest themselves in various treatment approaches or treatment programs, and they combine very nicely according to 12-step traditions. They simply define substance abuse as an allergy of the body and an obsession of the mind. This is truly a combination of the medical and psychological views. And whether you like 12-step philosophy or not, research repeatedly has shown that involving your clients in 12-step activities, AA and NA, clearly makes for more efficient treatment. But let's look at how some of these ideas play out in real life types of different treatment programs. This is basically a quick summary of different treatment models that we have. We have traditional treatment, which involves a recovery model, and in that we kind of blend anything together that works. The therapeutic community is a re-education or a re-socialization model. You have the self-help of 12-step interventions, and then everyone uses psychoeducational components in their treatment. It allows us to give the patients a cognitive understanding about what they're going through and a rationale for the treatment. We run into anti-abuse therapy, which is a form of an antagonist-agonist model, but anti-abuse therapy basically is the threat that if you drink, you will get sick. We have aversive conditioning or counter-conditioning, which was, I think, from a psychological point of view, an old attempt to show that the psychological model was right. And then we have recovery home or residential care, which basically tries to use long-term social support to produce change for the substance user.